Hi, this is Mrs. Lewicki, and this is number 2 of 5 PowerPoints on the cardiac system for MP4. Just want to review acute coronary syndrome. Now, you should know already, you should come understanding um, unstable angina, and we're going to talk more about the non-STEMI and the STEMI, the ST elevation and the non-ST elevation. Acute coronary syndrome is a spectrum of unstable angina, and I'm sorry, you should already know stable angina. Um, Non-ST segment elevation MI and ST segment elevation MI, in which ischemia is prolonged and not immediately reversible. Deterioration of once stable plaque. If partially occluded, vessel can be unstable angina or non-STEMI. If fully occluded, it results in a STEMI. Unstable angina is chest pain with new onset, occurs at rest, or has worsening pattern. It's unpredictable and is an emergency. Women frequently present differently from men. MI is caused due to sustained ischemia, location associated with coronary arteries involved, severity influenced by collateral circulation, and a complete ACS worksheet and chest pain case. Oh, sorry. Ignore that last remark. Women's symptoms may be different than men. Prodromal symptoms, which are like predictor symptoms that they have, they may have for up to a month before the MI, include shortness of breath, unusual fatigue, sleep disturbance, indigestion, and anxiety. Less often than men, they experience chest discomfort. Symptoms disappear after the MI. The causes and risk factors are all the same causes that you learned for heart disease: age, gender, race, ethnicity, and genetics. So those you should know. They'll have elevated serum lipids, elevated homocysteine. They may be hypertensive. They may be a smoker. They may have a sedentary lifestyle or be obese. They may have diabetes. Psychological states and metabolic syndrome and substance abuse are all causes and risk factors. Clinical manifestations are chest pain, and this includes a significant change in the pattern of pain, as I said, from stable angina to unstable angina. If they're having more frequent chest pain, it's unpredictable, then they've gone from stable angina to unstable angina. I talked about the symptoms already for women. In MI, pain is not relieved by rest, position change, or nitrates. Diagnostics include a 12-lead EKG, and we're going to do a 12-lead EKG, and we'll talk about those in a minute. But the 12-lead EKG is diagnostic, and it's different than the telemetry or the general monitoring that we do. We'll talk about that in a minute. They'll do serum cardiac markers, and that includes troponin, it includes CKMB, and they'll do a coronary angiogram or PCI, depending on what happens. PCI is percutaneous coronary intervention. My goal here, if they're having a STEMI, is reperfusion. So that may be through emergent PCI, thrombolytic therapy. They may get surgical revascularization through a CABG or open heart surgery. And drug therapy includes nitroglycerin, which is vasodilation, morphine, and we talked about that in an earlier presentation, that morphine will help relieve the pain, but it's not my first line of defense. My first line is the nitrates. I'll give the morphine. It helps reduce the preload, it helps decrease the anxiety, and helps with the pain. Beta blockers, ACE inhibitors, and antidysrhythmics. I also, and it's not listed here, if the patient's not already taken it, they would also go on aspirin, and I have that in another slide. This slide. So if somebody's having chest pain at home, the first thing that you ask them to do is rest. If they come into the emergency department or they're in the hospital and they're complaining of chest pain, you want them to stop doing whatever. You need to get them into a bed and a stretcher. If they're walking in the hallway, you need to get them to stop. You need to get a wheelchair and you need to get them into the bed. You're going to put on oxygen. You're going to make sure you have an IV. You have to have an IV before you give a nitrate, and we'll talk about that in a minute. You're going to do vital signs. You're going to do a 12-lead EKG. You're going to put them on a monitor, so the telemetry monitor. You're going to give nitroglycerin, and remember, nitroglycerin is a vasodilator, so they could very quickly dump their blood pressure. So I have to know their blood pressure before I give a nitrate because I have to know that. I need that IV before I give that nitrate because what happens if it does drop their blood pressure? I need to be able to give them fluid. Or what if they're in some dysrhythmia and I need to treat it? So I need to have an IV for that. I'm going to give them aspirin, and that's chewable aspirin, 324 milligrams. We want them to chew the aspirin. It's an antiplatelet aggregator, and by chewing it up, it gets into the blood system faster, keeps those. Remember, the platelet's job is to run to the area of injury. They're going to run to the area of injury and they're going to stick together to try start the clot formation. So that's their job. And we want them to not do their job. And so we give them aspirin, and then it's been described that then they're like Teflon going by that area of injury, and we'll give morphine. Now, what order should you do this in? And we look at MONA as the nomogram to help you remember morphine, oxygen, nitrate, and aspirin. You always want to put the oxygen on first because it's quick, it's easy, and having an MI or unstable angina, regardless of their oxygen saturation, their O2 sat, regardless of that, you want to put on oxygen because having an MI increases that myocardial oxygen demand. So you want to increase the supply. You want to make sure that you have vital signs in an IV before you give the nitrate. So, but the nitrate is my best drug to treat this. In the meantime, I can give an aspirin. I can give aspirin here. They can be chewing it up while we're getting vital signs because that doesn't impact my vital signs. And then if it's unrelieved with nitrate times 2 or 3, nitroglycerin, then you can give the morphine. But that's not my first choice. 12-lead EKG is diagnostic, and what you're looking for is ST elevation. And when I say you, I don't really mean you, the student nurse. Nurses, there are nurses who can interpret 12-lead EKGs, and there are many, and primarily it's the doctor that does that. But you're looking for ST elevation, and the ST elevation is in 2 or more leads, and that's why it's diagnostic. This one actually has ST elevation. You can see here in the V leads, and it's got some ST depression. But you're not, as a student nurse, expected to be able to identify that. Even as a registered nurse, if you're working on a floor where it's required of you, you will get lots of classes about that to teach you how to do that. The major diagnostic tool used to evaluate patients is changes in response to that. So you're looking at the ST, and you can have ST depression, which is what this diagram shows. You've got ST depression here. You can see it's down, and that's ischemia. You also have an inverted T wave. Or you can have ST elevation, which you have here. And this ST elevation is a sign of infarction. And things like ST elevation and leads 2, 3, and AVF indicate an inferior wall MI. And those are the kind of things you learn when you're looking at EKGs. It's 12 recording leads. There are 6 leads that measure the electrical forces in the frontal plane and 6 that measure the electrical forces in the horizontal plane. And what the 12, it's like a photo shoot with a model, and you're taking lots and lots and lots of pictures. That's what a 12-lead EKG does. You put the limb leads and the precordial leads on, and it takes the picture at the different angles of the heart. Coronary arteries. I talked about this in the previous one. Understand the main coronary circulation. Um, the right coronary artery, you see it divides up here, and you see where it's feeding. The left coronary artery divides into the circumflex and the left anterior descending, and the aorta is what feeds the rest of the body. When they have had a myocardial infarction, risk factors are unchanged, so I'm not going to review those, but they will complain about it being the worst chest pain they've ever had in their life. They feel like they have an elephant on their chest. It can radiate, and usually it'll radiate to the jaw, the left arm, maybe the neck, the shoulder. They may have diaphoresis. They may also have a little bit of nausea. Diagnostics, sorry, this is not the right diagnostics. We will do a chest x-ray, but the diagnostic is a 12 lead. 12 lead. And then the serum cardiac markers. I'll have to fix that on the slide. CK, troponin. I'm not going to write it all out because that'll take me too long. Treatment is same as unstable angina. The goal is 90 minutes from door to balloon for PCI. So if they get a radio call that they're getting a person with chest pain, or if they come present to the emergency room and say, I'm having chest pain, oh my God, there's an elephant on my chest, oh my God, the goal is 90 minutes to get them on the table and into the PCI lab. They will, if they live outside of an area that is doesn't have the ability to do PCI, within 2 hours of that, they will do a fibrinolytic. I think it's 2 hours of that, but the goal is 90 minutes. So if they live in a place, or if for some reason they can't, the cath lab's busy, they will do fibrinolytics. But the total goal is to reperfuse the heart. Fibrinolytics I'll talk about in a minute, like right now. The names streptokinase, alteplase, retaplase, tenecteplase, there's all kinds of names, and they're always coming up with new ones. Fibrinolytics are thrombolytics, and they break up the clot is what their purpose is. They're going to restore perfusion. We'll also use something like TPA if they're having a stroke. So their goal is to restore perfusion when they're not able to get to a center with a PCI. You want to administer it within 6 hours of onset of symptoms. And there is specific, I have on here meet inclusion criteria, but in fact, it's you want them to not have exclusion criteria. And exclusion criteria includes things like active bleeding, history of GI bleed, recent surgery, those types of things, or if they have a history of a bleeding stroke, then they're excluded from getting a fibrinolytic. The goal is reperfusion. What you will see, what you expect to see, so not normal, but because of what it does, you're going to get excessive bruising. They might bleed, but not hemorrhage, but they might have some bleeding. They will have what they call reperfusion dysrhythmias, and that means as the blood flow is getting back to the area of infarct, they will develop some premature ventricular contractions or even some VTAC. We usually start 2 or 3 IVs, and we don't do any venipuncture for these patients because of that. They will also be on a heparin infusion. Things that you don't expect. I don't expect for there to be bright red blood in their urine, in their stool, in their head. So if they, like I suddenly can't wake them up, that might mean they had a bleed in their head. So those are things that we watch for by doing neuro checks and regular assessments. PCI is the first line of treatment, and as I said, that's percutaneous coronary intervention. And a lot of you will have had the opportunity this semester, if you haven't already, to go to the cath lab and see this. The goal is to open the blocked artery within 90 minutes. The advantages is that it's an alternative to open heart surgery. It's local anesthesia. They're ambulatory shortly after the procedure. They have a shorter length of stay in the hospital and shorter recovery time. Because of all the advances with PCI, what we're seeing is that our patients that require open heart surgery or cardiac bypass surgery are getting older because of this. They pre-procedure, the patient has to be NPO. If they come in and it's emergent, obviously that's not going to happen. You're going to want to have IVs, a 12 lead, a chest x-ray, and if there's time for that, they will go in and they will do angioplasty, and what that does, and they go in usually through the groin, although they can also go in through the radial. And we're seeing more and more of the radial artery access. They'll go in, they inject a dye through the catheter, and it's guide wire-ish, and they will, when they find the area of blockage, they will angioplasty it. So they'll increase the balloon and kind of try to push that plaque against the vessel wall, and that kind of tries to tamp that down, as it were. And then they'll put a stent in place to hold that open. They do require, if they have a stent placement, that they need to be on certain medications, usually Plavix, which is also an antiplatelet aggregator, and usually Plavix for 6 months after the stent's placement. But now they have more clot-eluting stents, so it just depends on what got placed. Complications of PCI, rupture of the coronary artery. They could have cardiac tamponade. They could dislodge some plaque, which could lead to then a stroke or a worsening MI. And they could have issues with the contrast medium. Post-PCI nursing care, you're going to do frequent vital signs and neurovascular assessments. And that's every 15 minutes times 4. I'm going to try to write it out. Q15 minutes times 4. Then Q30 times 2, and then Q hour. You're assessing the puncture site, and you're also checking distal pulses to the site. So whether if it's radial, you're likely checking brachial pulses, and you're checking capillary refill of the hand, and color and sensation. If it's femoral, then you're checking pedal pulses, and they'll usually mark the area with the pedal pulse with an X on it. If it's femoral, the patient usually is flat. They sometimes can have their head of the bed a little bit elevated, but the most important thing is they want to keep the legs straight for 6 to 8 hours after the procedure. And you want to encourage fluids post-procedure because you want to get rid of that contrast medium. If they have to have bypass surgery, and that's for patients that failed medical management, have left main or triple vessel disease, not candidates for PCI, or continue to have chest pain after the PCI. Sometimes if they're diabetic or expected to have longer term benefits with the coronary artery bypass grafting, they will have surgery. And we're not going to get into all that goes along with that. I could teach you a whole class about that. But what you need to know is that they will use grafting. So they'll take a vein, usually the saphenous vein. Sometimes they'll do the internal mammary artery. And now they're also doing radial grafts as well. And they bypass the area of blockage. So they will take the area that's infarcted, they'll sew part of the vessel on, and they'll sew it so that they restore circulation, because reperfusion is my key. And that's the end of this part of the presentation.